Hi, this is Dr. Pajari, host of the Prognosis, which is a palliative podcast, and I'm very happy to have two wonderful guests here today. My first guest is Dana Bingham. Did you want to introduce a little bit about yourself, and then?
I'm Dana, and I am a hospice nurse. I've been a nurse since '92. I started with Florence Nightingale back in the day. Hospice is my passion now. It has been for several years. And that's it.
And my other guest is Teresa Williams. And go ahead and introduce a little of yourself, too.
Sure. Teresa Williams, and have never been associated with hospice. Didn't think I would ever need hospice until this year, but lived in Marietta, Georgia with my husband, who fell ill that we'll talk about. But I'm an executive assistant for a large corporation. Have lived in Georgia for many years, and this is my home. So thank you for having me.
Thank you for being here, both of you. Wanted to just have an open conversation today, which is really the focus of this podcast, a very open conversation about the hospice experience. So we'll start with you, Teresa. Tell me a little bit, it was your husband, and tell me a little bit about being diagnosed first and going through some treatments for illness.
So Lane was diagnosed with colon cancer 10 years ago and was able to have that successfully resected. Went through 6 months of chemo fairly easily now that I look back on it, and was cancer-free for about 10 years. And then a couple years ago, had something inside the soft tissue of his mouth come up, had to have that removed, so that was head and neck cancer, which then moved to the lung. We had that radiated successfully. Unfortunately, had already moved to the other lung. Tried to have that radiated, and then it had spread, and so we went the chemo route for 6 months. And after 6 months of different combinations of chemotherapy, decided that we would not go forward with that. It was not working and had spread beyond that. So it was stage 4 when we started chemo, and probably bought him an extra, 6 months maybe, 2 months maybe. But after that, then we decided to quit having therapy, and that's when they introduced us to hospice.
Teresa, tell me a little bit. One of the important things is that progression through illness, of figuring out over time that things aren't working. How was that for your husband? Was that a kind of a slow process, or was it a sudden process that, he woke up one day, or how did he come to the realization that things weren't working like he wanted them to work?
So certainly, when you find out you have cancer, that's never what you want to hear. And I almost think you're in shock in the beginning, and you're trying to find out as much information as you can from friends, from family, from your resources that you have. But I think not knowing what your resources are is scary. We felt like we had a really good team that took care of him, and so we were very trusting in the doctors that were treating him. But still not understanding how many options we had. So I had no idea there was a first line or a second line or a third line of chemotherapy, and that if the first one doesn't work, we can move to the second one, although maybe your chances of survival go down. I thought there was only one combination, and throwing immunotherapy in there, which was something that we had high hopes for. It didn't work for him. And so it seemed like with his progression, every time we tried to turn a corner and try something new, not that it backfired, but it didn't work. And so we'd get our hopes up, and we'd really pray for, some movement forward, and then it wouldn't work. So we felt like we got bad news after bad news after bad news. And so I think, unfortunately, through the progression of the chemotherapy, you feel so bad. And watching your loved one just go through that kind of deterioration of the way they feel is a very difficult thing to watch. And then to find out that it's not working, it'd be one thing to go through it and have it work, right? We could push through it, we could muscle through it, power through it, whatever. We're gonna be okay at the end of the day. But to go through all of that and then it not work, it's very disappointing. And so I think we stumbled our way through it. We had a good team, and I felt like they supported us and gave us the best options. But he was not the kind of person who wanted to try clinical trials or fly to, another state or another country and try different things. That just wasn't who he was. And at some point we accepted that and then had to move forward with hospice and try to make the best of the time we had left.
Mm-hmm. So a progressive decision over time and recognizing. Do you think when you came to that hospice point, or when he came to that hospice point, he was fully ready for it?
I think by then he was. We had had enough time to accept that was going to be the fate, and so you have to get on board with it. You still hope for as much time as they say, but he was given 6 months and he lived maybe 2, so. I was disappointed in that. Really had plans for those last 6 months in terms of travel and family and friends and just reconnecting to those people that he wanted to before the end of life. But with the progression, the deterioration was very quick. And so I'm thankful for the 2 months, but I feel like there's a very fine line and a point where you pray for them to live and then you pray for them to pass quickly, because there's a time where that quality of life starts to go down to the point where there are comfort measures that need to be put in place, and by then you need to accept that.
It's interesting what you just said, and this podcast is called The Prognosis with Reason, because I feel that prognosis is a lot of times overestimated or given to families in an unclear fashion. Was there some confusion about that? It sounds like you had expectations for a longer time. How did that impact you and him also?
Well, it's difficult to accept, and I wonder if it would have been better. Did the oncologist know it was 2 months or 3 months and just say that to sort of give him the will to live and to push him forward? Or did the disease truly progress so quickly that there was no choice? It was going to happen in that period of time. I certainly wanted 6 months or more and was really hoping for more, but it became evident a few weeks in that probably was not going to be the case. And not having gone through that before, you understand that because you see it and deal with it every day. But not having dealt with that before as a family, it was a difficult thing to watch and to try to understand what's happening next, how to be prepared for that, and how to get the most out of today. That was the one thing I figured out, that I couldn't worry about 2 weeks from now, I couldn't worry about 6 months from now. I needed to be present in the moment today and make the best of today.
It can really wreak havoc, I think, sometimes. I think you handle it well. You've been handling things well, but it can really wreak havoc for a family if they're given kind of an overestimation of time. Dana, you want to speak to that? You've taken care of a lot of patients, and I think prognosis is a pretty big deal. And not gauging it correctly or overestimating can really cause some issues on the hospice side. What do you feel?
I truly feel the same way, because when we get there and the patient's in distress or pain crisis, or sometimes they're sitting up talking to you and smiling, and they greet you at the door. It's difficult for them to accept that they're not going to have very long. And it's my role, I think, a lot of times to sit down and have the discussion with them, and with the doctor, also. But a lot of times they're given too much hope. A lot of times. But I try to make that time for them and let them know that they're supposed to reach out and spend every minute of the time that they have, like you said, to make every day count.
I think when we were told 6 months, basically the oncologist released us that day, and it was rather abrupt. I think we didn't expect that. Here we had been coming for 2 years off and on to go through whatever treatment was needed, and that was our family of support. Those were the doctors and nurses we trusted. And then for her to say, you don't need to come back. It was a kind of a final message. And, we were thinking, like, do we need another doctor? How do we get medication if needed? Well, hospice will take care of that. And so we're now turned over to a new team and have to go find a company and a group of people that we think are going to offer the very best care that we can get. And then we start down this new path of not understanding what to expect in terms of physical symptoms or, like you said, pain management or cognitive function, any of that. And it could be any and all of that. And so it's very overwhelming to the family as you're given that message and you're transitioned from that care to palliative care.
Yeah, that's actually a key point is with the transition, especially if you're giving that message, and it's an overestimation or maybe sending someone off with that. It's kind of the last thing that they hear and they fixate on. And it was, that prior experience. And here you are going in having to reestablish a relationship or new relationship with the whole new team. And that's where it becomes a little difficult too, coming in if there has been kind of a kind of underappreciation of where things are, is coming in as hospice providers. I know that we have that quite often, where you come in and you have to talk very openly about prognosis in a way that maybe hasn't been talked about before. Tell me now a little bit about the onboarding process for you with hospice, how that went.
So the oncologist had recommended that we go ahead and reach out earlier rather than later. I think experience from her standpoint in suggesting that, we're on the fence, right? Do we really need it now? I mean, we got 6 months. Why would I need it right now? But we did take her advice and go ahead and call and set up for hospice to come out. Our thought was you come in once every week or so, whatever's required. You put some eyes on him. You do the write-up. You take care of medication, make sure he's, in a good state of mind and physically doing well. And then you're off and about and come back another week. So we did that, and I think I'm grateful for doing that. I think when Dana came out and did the onboarding, she was very good about explaining how this is going to work, explaining some of the medical tools that we might need, whether it's seats for a shower or a hospital bed or a wheelchair or walker, so that we have access to that. I wouldn't have known how to get that done. And so she made that very easy. I will say that, sending the medication packet ahead of time and having that prepared and there, you sort of put it on the shelf or in the refrigerator and think, maybe I won't need that for a while. But sure enough, there's going to come a day when you do, and you're going to need it there. And you don't want to have to start that relationship at that point and then be scrambling to catch up, if you will. You want to stay ahead of it. Just like pain, you want to keep the patient comfortable, and so that made us feel really good about getting in early and getting onboarded as soon as we could. It wasn't our preference, but it turned out to be the best decision we could make.
Do you think his symptoms, and this could even be before with chemo and things, do you think he was well managed from a symptom standpoint? Were things addressed? Symptoms become a very dominant part of hospice. And I think people don't realize that either there's perhaps a perception that things are going to be static for a good period of time. And actually, it's quite the opposite, where we get patients where we are actively managing, dynamically managing day by day. Do you feel like his symptoms were managed well and pretty okay, or were there fluctuations, or how was the symptom management all along?
So with Lane, it was interesting. In the beginning, he didn't have a lot of symptoms. He wasn't on a lot of medication coming in, and he wasn't in pain except for, say, a lower back issue that we weren't sure was cancer. It could have been lack of muscle, core strength, something like that, because you have to remember he's coming off of 6 months of chemo, so he's cumulative feeling worse and worse each week. So we were hoping that we had a month or two where he'd start to feel better coming back off the chemo, and that's when we were planning our travel and planning to see friends and family, because we knew at some point it would start to go the other direction. So I think at first we didn't need a lot of pain medication. It turned out as we got to the end we did, but not, I would think, compared to some patients, not as much. So for him, he didn't have pain all over, and there were really not a lot of other symptoms that he had. So it was really just pain management for him and trying to figure out the right combination, the right cadence of what that was. So I think we managed it as well as we could, and I'm grateful that he didn't have a lot of pain until literally 48 hours maybe before he passed. So I'm grateful, because it could have been months of managing that. And I understand, the more pain medicines you take, then you're losing that ability to communicate and have really good conversations that are so important at the end of life. There are things that you need to say and things you need to know, and I'm really thankful I got the chance to have those conversations before the end, and make sure that family knew and got to come by when he was in a better state of mind and could really communicate well. But he knew it was coming, but I don't think he knew it was that quick. I think at the very end he probably did, but I think he still had hope that it would give him as much time as he wanted, more time than he thought.
Dana, did you want to say something on that? You were thinking about pain management and symptom management in patients.
Yes. The way I go in, and I start watching the patient from the time I get in there. I also send a video every time to the doctor, and that's my backup. But he had a lot of neurological things going on at the end, which we all agree that we all thought maybe it had metastasized to the brain. But you watch the vital signs, you watch the expression, how much they've been awake, how much agitation's going on. And if you stay on top of it, you don't get behind, and they don't suffer. And there's a lot of people that don't believe in, they think morphine is going to take them immediately, because that's what they've been. I mean, every time you mention morphine, and it's not an ugly word, it really isn't.
But you're right. I will say that's exactly what I think. I think they're about to be unconscious and, cognitively go away someplace, and that you won't be able to have a good conversation. You think they're sort of slipping into a coma in a way, and they're not going to be available.
And there's a lot of education that needs to be done there. I think that's why there's such a need for something like this, and also education that this is a niche specialty. And I say that a lot because It's really about knowing different narcotics and how they work and different forms that you can administer narcotics. And, a lot of people just have an idea that it's morphine and morphine alone. But we've got a lot.
I've learned that.
We've got a full armamentarium, full medicine chest, or medicine cabinet of medications to be able to medicate people effectively. And we use them. And then, as you saw, we can do anything from the most minute dosing to the most aggressive dosing. I think that that's one of the areas where a lot of people just don't even understand that. They don't have that knowledge.
Agree.
And then they have a fear associated with it, and they're afraid to commit. And very much as Dana said, I think one of the real dangers is if you don't commit to medicating, that patient will suffer. And a lot of times people don't necessarily recognize what the suffering is. They think that the patient is just doing okay, and actually there's an element of distressed breathing or pain that's uncontrolled, certain other elements, and that can be tough. That can be a tough thing to come into. So do you think he was well managed from a pain and from a symptom standpoint? It sounds like overall you think that the management was good.
Overall, I think it was. It was amazing to me that he never had pain in other parts of the body where we knew there was cancer. Mm-hmm. I guess I assumed that if I have cancer in the leg or the hip or the back, it's going to hurt there. Mm-hmm. And for him, maybe it did, but it only felt like it was coming from that lower back area. Mm-hmm. And so that seemed manageable with just I think the lightest of pain meds, considering what's on the spectrum of what could have been used.
He didn't take a lot. I mean, he'd never had to take a lot of medicines in the past.
No.
Until the end. Mm-hmm. And I think he had been hurting for a little bit and was trying to shake it off.
Yeah, and I think maybe he didn't share with us how bad he was in pain. I think he had a high tolerance for pain. Yeah. I do as well. So I have the ability to endure a lot before I need something. And I think he was that way as well. But other than that, there weren't a lot of symptoms until the very end, such as the distress breathing. And, he did have cancer on the lungs, so doing those breathing treatments 3 times a day, very helpful. And also taking the pills for secretions and whatnot. So I felt like he had a good arsenal of meds to take care of I don't feel like there was anything that ever came up that I wasn't able to call and get you to help with and quickly. Mm-hmm. Luckily we didn't need anything from an emergency standpoint because again you sort of had that well in order and we had that ready and available. Mm-hmm. And I think the way your organization works is being able to get something delivered quickly or having the nurse come out quickly is a comfort to the family. Me not having to worry about if the situation changes and not being educated on what to look for, what to be ready for, I think was a good thing. So I think you've done a really good job of that, and I think that's very helpful to the family in that case.
Talk a little bit more about that. Actually, it's a big part of what we do also is, and I actually believe in this so much, is having upfront and continuous conversations along the way, just to let the family know, here, this is what I'm seeing, and and imparting that to a family. Or the nurse doing that too. And I think it makes a big difference. Do you think that helped you in this situation to gauge, especially as we talked, originally 6 months, and then you're seeing someone is rapidly declining and you're thinking, well, this isn't adding up. Does that help to have those conversations plugging in periodically and saying, hey, this is what's going on and here's the reality and here's how we manage it?
Absolutely. I'm a kind of a straight shooter. I want to know the real deal. So I expect to have a conversation that includes tough, decisions and tough information to hear. And that's okay. That's the way I preferred it. I could see where there are families that absolutely don't want to have that conversation. But personally, it was very helpful for me. So we went from having conversations around, I think it's going to be months to weeks and days, or days and hours. So that was very helpful for me. And also understanding the physical things to look for as a patient starts to pass or transition was very helpful, so that I wasn't caught off guard and I could help manage that from home. Because even though hospice is coming in a couple times a week to help bathe them, and of course Dana's coming in as needed, could be daily, every couple of days, whatever's needed, the family's then left to take care of the patient the rest of the time. And so understanding what to look for and what not to be afraid of, and what to do if something happens is very important. So I think the more you can educate a family on what to expect, whether it's timing, whether it's you're going to start to notice distress breathing, or if this happens, here's what we can do to take care of that, the better.
Tell me a little bit, I was just thinking when you were talking about family, how did your family, you're very, very straightforward, and it's a very good quality, so, you can be spoken to, and you can ask the questions that are on your mind, and you're right, a lot of people struggle with that, and that makes the process more difficult of confronting reality that's in front of you, which, that's tough. How did your family, loved ones around you, do you feel like they understood or had a good idea of what was going on? How did they deal with the process?
So we don't have children, and so it's just the two of us at home. However, we do have a lot of family nearby, and everyone was very supportive, had been following the progression of his disease over the time frame that we were looking at over a couple years, and we're all very supportive and ready to help step in if needed. So there was no one that was fighting back, or there's no drama, thank goodness. Everybody just showed love and concern and support, and wanted to know if they were needed, what they could do to help. So I'm very blessed and lucky that was the case, and Lane, realized that, and that's just the way our family life is. And so it worked out fine for us to have friends and family come in and help. I have neighbors and other friends that are basically family, who would do anything for Lane or myself. So we were very well supported and had a wide net of support as needed. So that was very helpful.
Did you feel you were supported? Hospice also does grief support. How did you manage that aspect? Sometimes that's the one that we kind of shove down deep within and get on to practical matters, and then it's still there in the background. How did you manage grief?
So
and
are
you still?
Yeah, I did speak to the chaplain, or I'm not sure his title, and his staff, and they were very helpful. We just had a couple of conversations, and even someone came out and sat down, the social worker from your organization. She was very helpful just to chat. At that time, I'm still thinking I had 6 months, so I was very eager to connect with other people in the same situation. I wanted to be able to ask, what should I expect to feel in terms of grief beforehand, before, during, and after. And I'm still looking for that support now, that it's after the fact. But I think they were willing to connect me with other folks, other patients, other families, and I think that was something that provided me some comfort. And unfortunately, with the progression of his disease, we didn't get a chance to connect. But I do think if there is a chance to offer that, it's very helpful. From a religious standpoint, no matter what your religion, and a spiritual connection, but just in support in general from that aspect of it. The families are going to be different, and they're going to need different ways of support with resources, and I think any way that you can help with that is very much appreciated. Unfortunately, I didn't get a chance to move forward with that, but I had plans to do that and to connect with another family or person that was going through the same thing that I was. I thought that would be very beneficial.
Did you feel like you did mention this? Did you feel like you had an opportunity with Lane to have quality conversations that gave you closure? I think that's a big part of it too, don't you think? A lot of families don't get closure for various reasons, and I think that's what we try to avoid, is trying to give people closure before that final death happens.
We were able to give y'all a few more days whenever the neurological thing started, yeah. And I think that I think that helped you probably more than anything else.
It did. I felt like there were a couple of conversations around service and remains and things that he might want to have distributed to family and friends that I wasn't clear on. And I'm glad we had that conversation, because I thought we were on the same page, but we weren't on the same page until we had that conversation. And so I actually did go down a different path for his service than I originally thought. And I'm so thankful that I did. I feel 100% confident that it was the right thing to do. And I feel like he was really pleased with the service, in spirit. And having that conversation was very beneficial. So it gave me the few extra days to. There's a good and a bad with that. When he's feeling good, you hate to have those conversations that are kind of a downer, really, end of life conversation. But I think at that time we were so kind of on board with what was going to happen. It was an easier conversation to have. So very happy that we had that. And I was able to then execute on the things and make sure that, and I'm still doing that because it's only been a couple weeks, to make sure that his wants are being executed the way that he wanted.
Do you think he had a sense, I believe this personally from all of the patients I've taken care of, do you think he had a sense that he was going to pass soon?
I'd actually asked Dana that question.
I think he did.
I'm curious to your opinion on that.
I think he did, because, there was a couple of times that I visited with him when you were not there. And I don't know if he was, reluctant to let you know that he was having the increased pain. And, but I think he knew things were going a little bit too fast.
I think he probably did too, but we did not have that conversation. And that may have been just him protecting me. And I think at the end, it was, I had been there, night and day, taking care of him 24/7 as needed with the help of the team. And I did have a caregiver come in a couple of days for a couple of weeks. Tremendous value and help. And I am ever so thankful.
Will you talk a little more about that? That is
Sure.
such a key point with families. They don't realize that they may need the help, and they don't realize things are going as rapidly as they are. And a lot of caregivers think, I can do it, I can handle this, I can take care, and it's not easy.
Oh, and that would be me.
Yeah.
I handle a lot of things at the office, and I'm able to juggle a lot of different things, and I thought I could do this as well. I did start to realize as he started to decline that there were things that I was going to need to be there for pretty much 24/7. And everybody was very vocal about making sure I knew that I needed to take care of me, and that I needed to make sure I was not going to wear myself down or burn myself out or get sick. And so...
And to just be a wife.
Yes.
Instead of a caregiver.
Yes. And that's hard. It's hard to do everything. But I wouldn't have been anywhere else. That was the only place I would have been. But I'm still working full time. So just the balance of working from home and also keeping one ear out to make sure, he's not going to fall or he's not going to. So I actually installed a little Ring camera in the room where he stayed so that I could watch him from my cell phone. So if I stepped outside to get the mail or postman came or whatever, I could make sure he wasn't trying to get up and because he wasn't stable and able to stand on his own, because he thinks he can still do certain things, and the mind, wants to do what it wants to do, and yet physically he's not able to do that. But so I decided to bring in a caregiver a couple of days, 1 week, and that was really just to give myself a little bit of time to do some work, to run, some errands and do some things for myself that I felt like I needed to do. Dentist appointment, things like that, that you don't think about. All of a sudden, you're tied to the house, and you can't get gas, you can't get food. I mean, so there are a lot of things that you aren't thinking about where your lifestyle is now completely changed for this period of time. And so the caregiver was amazing. She came in, she knew what to do. She wasn't concerned with any issues in taking care of a patient at that state. I was able to have some friends over and family and visit and get out and do a couple of things that I needed to do. And it was amazing. I should have probably done it a couple more days, but it gave me enough time to feel normal and also then feel energetic about taking care of him, when I was there. So we only did it for 2 weeks. She was actually there the day he passed and was very helpful. I had stepped out to take a nap because I'd been up with him pretty much all night, and I had only been asleep, 30 minutes. She comes in, taps me on the shoulder and said, "I think you need to get up and come back in." And when I got back, he was gone. So,
we see that too. Dana, you want to say something? We're both thinking the same thing, but
They don't want to do it in front of you.
That's what I've heard.
They really don't.
I've read that a lot.
And as soon as they just let go. As soon as if you're distracted or if you're laying down, they let go.
We've seen that before when there's a close bond and it's tough for that person. I think subconsciously, the subconscious is still active in the dying process, is my belief, and that the patient may still have that connection and have a sixth sense, so to speak, that there's proximity still and not wanting to hurt, and then passing away in a moment where they can alleviate that. So, yeah.
That was okay. I didn't feel the need to be there. It was certainly about him being comfortable and feeling the right time to transition. But it was an interesting process over the last couple of days in watching the physical changes and the mental changes, obviously all during a little bit more of pain management. So not having full conversations and not really understanding, does he know what's going on? Does he not? And at what point they do decide to let go and that it's okay to transition. It was quite something to watch. Not all good, but not all bad. And, I'm just forever thankful that I was able to be there with him, have him at home, which was very important to him, and be able to have that go peacefully, calmly, who could ask for anything better than that?
You just said something I like a lot. It was quite something to watch. I think that dying, and that's why I'd like to have these conversations, is I think that dying is quite something to watch. It is a fascinating and difficult process that we really need to understand more about, have discussions about, and a lot of what you mentioned is very key to getting that knowledge. Like you said, kind of coming in more prepared. One aspect on caregiving, sometimes people don't realize, and Dana and I have talked about this before, is that caregiving can even be done medication-wise. A lot of hospices choose to ask families to dose around the clock or continuously give medications, but it's nice when there are other options. So talk about that. I was going to say, Lane had an infusion at the end of life, and that kind of took the caregiving a little bit out of your hands, in a sense, not having to worry about giving medications around the clock. Did you feel that, or maybe not
Yes.
so much?
And that was really the last 24 hours, maybe a little bit longer than that. And I felt like that was helpful. I didn't have to worry about every 4 hours having a pill or making sure a patch is on or off. You know, it's overwhelming in and of itself, the whole process, but to try to make sure you're then dosing correctly when you are the caregiver is something that you have to be concerned about. And so having that morphine drip at the end was helpful, and I think it kept him comfortable. I did have to give him an extra dose when I thought he was agitated a couple of times, but it wasn't a lot, and so that made things a lot easier, and he was comfortable, and that was the important part at that point.
Yeah, and Dana, did you want to say something on that too?
He was agitated that really bad the day before he died. I mean, that's when we started the drip, and
is that normal? I don't know.
Agitation, yes, and I think that's where a lot of discussion needs to happen, education needs to happen, is that dying itself, the transitioning process actually can take on many, there are different forms it can take on, and agitation, absolutely. And sometimes we need to really go quite strong with the medications we use to try and get that to a calmer place. That's why there's kind of a myth, maybe perpetuated by films or whatnot, where people think you're going to be on your bed and just still talking and still interactive. It's not like that. It's almost like a birthing process. Yeah. It's the reverse, right? It's a going out process, but a very powerful transformation. And some patients, depending on what they have for pathology and for disease states, they can be impacted in a pretty significant way. And there are things to actively manage as they're on their way on out, especially, as I said, giving them peace. I think people are not realizing it's really, the patient requires that. But again, you have to also not mistake everything for a painful or a disruptive process. To watch dying, to watch that process can be actually quite a fascinating but a tough process. Not everything needs to be medicated aggressively. There are things that you see that may not sound nice, or may not look great, but are part of the process. And then there are things that are more difficult and do require some management. And I think
the interesting part is not knowing what to expect.
Yeah.
My mother had passed away in the hospital 25 years ago, and in the ICU, she's hooked up to all these machines, and they can very specifically tell you the things that are about to happen. You can watch the numbers start to drop, systems start to shut down. And so it was a very methodical process and not peaceful. I mean, the passing was peaceful, but you're surrounded by monitors and people and buzzers, and, it's just a very overwhelming place to be. Hospice, on the other hand, you're able to have someone at home in the comfort of where they are the most comfortable and are surrounded by friends and family. And so that experience is completely different than being in a hospital. And so I'm very glad and lucky that we didn't have to have him in the hospital. We could have him home, and he wasn't connected to a lot of machines, and he didn't have to do a great deal of things to get him to the end. And so I think that was a blessing. I think watching that process, I'll never forget it. I learned so much, but I was curious if that's what tends to happen with every patient, or like you said, it sounds like there are different pathology reports, and so some do handle that differently, last longer, require different medications, and then of course the passing could be completely different.
There's a lot of variety in some ways to dying, and then there's also a lot of similarity between cases, and knowing the difference is very crucial.
Right, and that's very crucial to me.
Yeah.
I depended on you to tell me what was similar. Like, I've seen this before. This is typically where we're at and what's going to be expected. That was so helpful. I cannot tell you how much that helped. Yeah. It was amazing for me. Again, straight shooter, I want to understand what I'm up against, and if I've got hours, if I've got days, if I've got weeks, that's fine. I can deal with that. But you knew that. I wouldn't have known that. And thinking I've got 6 months, and then all of a sudden weeks, completely different way to approach it.
I appreciated very much that you, in being so straightforward, you had trust. Don't you think that's the key thing? It's having trust in who we are, that this is what we do day in, day out, and that we really do have an expertise that is not the average expertise. It's a different form of medicine. And you having that trust in saying, I believe that what they're saying is actually what's happening. We get a lot of pushback from people saying, this is not what's happening. It's a form of denial, so I have compassion for it, but it makes it very, very hard. And those are the cases often that don't have closure. Something gets pushed down or the grief gets stuck because they don't have that trust that what you're telling them is actually occurring. And you're trying to put things in place quickly and make sure the closure's there and it doesn't happen. What do you think about that, Dana, too?
They made it easy for me to take care of them.
Yeah.
They were receptive to everything. They listened. And it's like you said, there's people that they're everybody's a full code. They want everything done, and I'm watching it unfold. Just like with him, I knew what was going on. So did Dr. Bajari. We don't hide anything. We try not to, and we're not going to sugarcoat anything either. We don't come in like a raging bull either. But a lot of people are scared to let go.
I can understand that.
And it's very difficult for us to take care of patients that are in that mentality. I'll say it's we don't come in there and over medicate or anything like that. We try to keep the quality of life and the lucidity, as long as we can. But there's a lot of people that are in denial. It's sad, and a lot of times the patient suffers from it.
Yeah, it can be the patient, but interestingly, it can be the family. The patient may be on board, or I think patients have a sense. That's why I was asking you about Lane. But I think families can be very tough in all stages of grief or all stages of denial. Sometimes it's about control, too. And I appreciated that you had trust.
Absolutely. We were in territory that we had never been in and waters that we didn't know how to navigate. And we're going to have to trust you as a team to help us get through that. I can't imagine not doing that, but I could see where there are other families that might be reluctant to accept it. I think we had enough time to accept the diagnosis. I think Lane sort of knew, from years of smoking that something might catch up with him, and those were choices he made early in life. That's the way he wanted to live his life, and so he did that, and he lived it every step of the way that he wanted to. He certainly wasn't ready to go. He wanted to be here. There's so many things we wanted to do. He had only semi-retired from the Georgia State Golf Association, and so we had quite a few tournaments and things that he still wanted to participate in, but I think a few months out he had sort of accepted that fate and really had an amazing outlook on it. He didn't like it, and he thought it just really stunk, but he also had a very strong faith in the way he was raised. His father was a Baptist minister, and so he had a very strong Christian faith, and that was what got us through. So I can't imagine not having that.
Yeah, no, I appreciate that. I appreciate it. I wanted you to talk a little more about him as a person. I think anytime we talk about dying and death, it comes down to a person, an individual, no matter where, how, and they have beautiful qualities. So will you talk a little bit about him? You kind of alluded to some of it, but what kind of person was he, and his legacy? That was the important thing.
Amazing. He grew up in South Georgia. Again, father was a Baptist minister, and they moved from Moultrie to LaGrange, and he finished high school in Moultrie, Georgia, and then went to college in LaGrange and played on the golf team there. Started playing golf really young. Even worked at the Sunset Country Club down in Moultrie when he was 15, 16 years old, and played a lot of golf, and was fortunate enough to be hired as the tournament director for Georgia State Golf Association, and that's a role that he fulfilled in one aspect or another for 30 years, and so became an expert at the game and worked at the highest level for the USGA in conducting some of the qualifiers in the state of Georgia, as well as doing events such as the U.S. Open, U.S. Amateur, U.S. Mid-Amateur Committee, and gave rules seminars on the game, and wrote articles for the Golf Georgia magazine, and it was a legacy that we never expected for him to create. One of the last things we were able to do is to create an endowment scholarship in his name, and wanted to do that before he passed away. Usually it doesn't get set up until after someone has passed, but with the folks at the GSGA and the foundation, we decided to try to get that up and going before he passed. And so for 5 months we had kept this a secret from him, which is crazy and amazing that somebody didn't let the word out. But our goal was to raise $50,000, and when we finally announced it, it was right before he started to get sick. We had raised over $103,000, so we'll be able to probably give 2 scholarships instead of one to a deserving person, and so really looking forward to that. He was hoping to help select the final candidate, which will be done in a few weeks. And so unfortunately he didn't get a chance to do that. So I'll get a chance to do that, which is fantastic. But just received a lot of accolades and awards. He's in the Georgia Golf Hall of Fame. He was inducted in 2016 for the work that he has done in the industry and the game and the that he's given back to the game so much. And so just really blessed and amazed at what he was able to do, the places that we've been, the people we've seen. The golf is a game where you make friends for life, and that's what he always said. And that's an amazing legacy. He will be missed by so many. And we're just all thankful that we had him in our life as long as we did. It just wasn't long enough.
I was just thinking there's a divine timing to some things, too, when you were saying it was just in time that he could appreciate it still. Yeah, I appreciate those things. I think that we think there's a divine timing in a lot of things that we see. And, I really appreciate you coming and speaking with me, and Dana also coming and speaking today on this. What's your next phase or chapter right now? You just working on you and
Sure.
taking it slowly?
Taking it slow, still work full time.
Mm-hmm.
It's awfully quiet at home. Probably getting a pet again. We had a Dachshund for 16 years that we had to put down a few months before Lane, was diagnosed. So last year, it's been a quiet time at home, but doing some traveling, definitely connecting with friends and family. I've got a really good support system and friends and family that are taking good care of me and making sure that I'm okay. And I think I'm still a little bit in shock, to be honest. I feel like almost he's on a golf tournament trip and he just hasn't called, and one day he'll show up, but I know that's not the case. But so I'm just going to deal with it day by day, and I'm going to go through the grief. I'm not going to avoid it. I think you could medicate through it. I'm not that way. I think you need to experience, because I think I'm going to learn something from it. I'll learn something from the whole process that I'll take away. And I'd like to give back to the game of golf, because it's been so good to us. But also, I wouldn't mind trying to figure out a way to help others that are in this same situation, because in the beginning, it was scary. And and I didn't know where to look for resources, someone to talk to, a support group. They just didn't seem to fit what I needed. And if there's a way that I can work with the organization and figure out a way to help others, I'd like to do that if I could.
I think you're doing a good job with it just by speaking today, getting the word out on what your experience was with
I hope
hospice.
so.
Yeah,
Maybe.
absolutely.
If it can help anyone,
absolutely,
it's worth it.
Yeah, I appreciate it. Thank you so much.
Thank you.
And Dana, is there anything else? I know you so
This
well.
is our model. This is our model. I mean, this is what we aspire every family to go through. We want everybody to know that we're on the journey with them. They're not alone.
Yeah,
Ever.
absolutely.
And I felt that.
Yeah, absolutely.
And it was very helpful. I can't imagine doing it alone.
Thank you.
Thank you.
Thank you so much for watching, and stay tuned for the next podcast. More to come. Thank you.